Hey everybody, welcome back to The Pathway. It's Taylor Henrik. I'm here with my colleague Sarang Patel.
Hey guys.
Today we're going to be focusing on psychiatric medications, possible medical comorbidities, mitigating risk for our clients who are on these medications, and some of the other barriers to access that our clients face on a daily basis. Let's drill down on this experience. Let's drill down on this topic.
Okay.
We know that there are certain medications out there, and just to lay the landscape for us today, talking about different psychotropic medications, whether you go from one class to another, talking about your typical antidepressants, your mood stabilizing agents, your antipsychotics, your stimulants, your anti-anxiety medications, you name it. Each class comes along with a class warning. Not just talking about black box warning, but typical side effects, easy to find online, included in all of these medications package inserts. You're going to be able to see in their own clinical trials where those percentages were, what the most common side effects are, and how they might affect your body. Talking about side effects, adverse effects, and then talking about specific physiologic or metabolic changes are kind of two different conversations. Why don't you lead us down talking specifically about metabolic changes, physiologic changes, or what can be provoked by these medications and how we have to be cognizant of that?
So let's start with antidepressants.
Okay.
Just because they're probably the most commonly used meds. So the class in general, right? And I'm sure I'm going to miss some of these things, but there are general class warnings. Or I would just say things that people always talk about.
Mm-hmm.
So let's just say, and you don't have to extrapolate just an antidepressants. You can say antipsychotics as well.
Mm-hmm.
We'll use both of those. Or mood stabilizers is weight gain. And we use that because it's a big hot topic anyways for us recently, right? With the GLPs all being around and all that stuff too, is weight gain being a big risk factor for a lot of these medications. Each medication has its own percentage, its own risk. We all know that. Every medication is a bit different. It's personally how I prescribe medications because it's trying to figure out what's the cleanest option. So the risks may be there, but you try to figure out what you think would be the best option for the patient that could hopefully mitigate those risks a little bit.
Absolutely. And this calls upon a previous conversation that you and I had, that we both have a lean or a tendency to use some of the newer medications on the market, whether it's the NDRIs, whether it's the third gen or newer antipsychotics, maybe some interest in moving towards the LAIs. There are certain medications out there that may mitigate or decrease your risk or of longer standing side effects. Mm-hmm. Michael, in the community mental health setting, with your experience at Team Wellness Center, do you see managing the whole individual and looking at a comprehensive view of the client, offering both medical and mental health related care? How do you keep in mind medical comorbidities as you have your providers or your prescribers focusing on prescribing medications?
The easiest one to look at, I think, is tardive dyskinesia. When a person has that, uncontrollable, the shaking of their hands or whatever, because we have to, in community mental health, formally, we have to, the prescriber has to check for that every visit if a person is on a medication that has that as a potential side effect, so that they are as proactive as possible, either DCing that medication, titrating them to something else, or giving them some of the newer drugs that may combat that a little bit, I guess. So we see that. So we're paying attention when we know to pay attention. I think some of the ones that get past us as far as watching closely are the weight gains. Mm-hmm. And then when you think about all the side effects or health risks that come from being overweight and obese and stuff like that. So we miss those more than we would miss like the tardive.
Absolutely. And in any setting, whether you're in psychiatry or in primary care, wherever you're treating these types of clients with these types of medications, it's prudent to know what the yearly or biennial guidance is in regards to labs. Commonly, if you're a client being maintained on these medications, we look for a CBC, right? A complete blood count, a glucose level, a lipid profile, at least. That's your bare minimum on a yearly basis. Other medications may call for a variety of tests, right? Whether it's therapeutic monitoring level, or if it's something more specific, such as a prolactin level or checking the liver, you name it.
But when you go at, like when you mentioned the CBC, if a person is not a prescriber and they're just involved in the treatment, the therapist, the case manager, whatever, they may not understand that. You know, they may not understand that this is what we should be looking for. This is when these labs come back. Matter of fact, they may not even always know that that's what should be prescribed to look at, because historically there's been a silo between physical health and behavioral health. So they're thinking, oh, the psychiatrist is only going to look at psychiatry. And if I'm not actively involved in their physical health on the treatment team, I'm not even going to think that way. So our job now is to really try to bridge the two so that they will understand those both sides are still working together with that same person.
That's a great point.
That makes sense, yeah.
That coordination of care, right?
Yep.
Classically known as coordination of care, or that unification of those two sides. I think Sarang and I both have medical backgrounds, so it feels almost like second nature. But when we onboard new providers, we always focus on that. Maintaining and having routine monitoring in place for lab values is a huge thing. And we know that it's a bit of a gray area. It's a recommendation. It's a suggestion. There isn't anything necessarily hard and fast, but we try to make sure that we adhere to those guidelines for all clients on any medications that may be playing a role.
Yeah.
What we see in community mental health a lot, because of a lot of our patient client, our clients are homeless. And so they're not living in the cleanest environment. So hygiene and that kind of stuff is a problem. And we often see people who, because they have a severe mental illness, if they have a personality disorder and they're schizophrenic and it's 100 degrees outside and they're wrapped up, you know, like a beekeeper. You're like, What in the world? Why do you have on so many layers? And then you start to unravel those layers physically, and you see hidden sores that are there that won't heal and stuff like that.
Sepsis, yeah.
And then you're trying to figure out, okay, now how do we help in that regard, and how do they know? Well, this person all along is a diabetic, uncontrolled, and you start seeing that kind of stuff, and that's where a lot of risk lies.
That is a wonderful contrast. In the private practice setting, my mind goes to thyroid. My mind goes to anemia, vitamin D deficiency, right? Stuff that is like, I won't say easily treated, but with the right regimen and proper adherence, follow up with a PCP and an endocrinologist, you can take control of these types of things. When you're dealing with an underserved population, it's a very different conversation. You're going to be thinking more globally about underlying heart disease, risk of infections.
Yeah.
I would think that there would also be concern for something like hepatitis. You may not
big time.
know, based on the environment that they're exposed to, what could be an underlying problem. Your screening has to be a little bit more broad.
Yeah.
Would you agree?
Oh, 100%. The latest thing that came across my desk where it was really, really scary is we got a new patient, and they were on the campus, let's say 3 days, because some of them stay in our overnight program. And the person was limping really badly. And then we come to find out when we took them over to primary care, because we have that on the campus as well, they have gangrene in their feet.
Wow.
Damn.
Yeah. That
And
doesn't
it's
develop
like-
overnight either.
It does not develop overnight.
Gangrenous wounds are what? Weeks to months at the very minimum?
And then when you start really, looking at this from a comorbid perspective, the question is like, why did you allow this to get like this? So why are these people dressing like this and this? And it's because either they are paranoid with their schizophrenia or paranoid delusional, but a lot of it is just fear. Like, I feel like if I'm in an institution, I'm in this homeless shelter, I'm around all these people, self-preservation. So I'm going to protect myself. I'm going to wrap myself. I want to make myself look as unappealing to a predator as possible. And these are some of the side effects you get.
So a defense mechanism.
Yeah.
It's a survival tactic, but inherently what they're missing is the care that they need.
Correct.
And these underlying infections can probably lead to quick hospitalizations and other complications.
Correct. And well, not quick hospitalizations. That's the scary part.
Long-term hospitalization.
Yeah.
Yeah.
And if they get the care, and then so when they finally get the care, it's urgent or emergent, and it's not routine, and so now you got all this added cost, and it's really bad.
But where's the funding for this anyways, right? Let's say like you have someone on campus that has a big medical issue. There's not enough funding around, not that it's all about finances, but you're treating mental health, you're treating this aspect of it. You know, you need to treat their diabetes now we're talking about, for example, right? You should be able to tackle it. maybe not treat it, but then give them the right resources, get them in play, in the same clinic. But there's not always funding to do that.
Correct. So if there's not funding, then you're looking for an FQHC. You're looking for a charity grant to help fund it, those kind of things. You're hoping that the person has Medicaid, so that can cover some costs. But you're right. We always fight that battle too in community health. That where is the funding going to come from?
That's where we can try to make sure that we're aware of community resources, if there are any available, right?
Right.
If it's a pro bono walk-in. There's some in some communities that we could probably cite. One that I used to be familiar with was in the Ferndale area. There was a care center there that was able to help individuals who were otherwise underserved. I'm sure there's a plethora of them out there. But us as administrators or being at the heads of our companies, it is important for us to be aware of where we could send these individuals to make sure that that stuff gets done, or as prescribers or providers ourselves, making sure that we order those lab tests and make sure that we maintain and monitor.
And even if you order it, see, I'm sorry, I keep going back to just because the community mental health culture is so different. If we were in mainstream culture, you would say, okay, I'm going to refer you to this specialist or that specialist, and you anticipate that 95% of your patients are going to follow through and go. In community mental health, it isn't like, am I going to go? It's, can I really get this person there? So a lot of times on our campuses, if there's no primary care physician for that person on our campus, meaning they were defaulted by their HMO to a primary care across town that they've never seen, they're just on their rolls, they don't go, they don't have physicals or anything like that, right? So we say, okay, well, we need this person to go to primary care. And we can almost grab them by the hand, walk them into primary care. And when they are sitting in the office waiting on the prescriber to come in, their anxiety gets the best of them and they leave. Or they'll flat out tell you, I'm not going, I don't care. And they'll walk off and wait till a couple days or whatever to show back up thinking you've forgotten about it. And you're like, why is this? So I went on this really deep dive last summer and tried to figure out why would a person otherwise not want to go to primary care. And I can't even say this without being emotional a little bit. Project Dignity is what's in my heart to do. So I tried to start it, and I'm trying to jumpstart it, because the reason that they don't go is because you are going to tell them to disrobe. So imagine being a person who doesn't shower, who doesn't brush their teeth, doesn't have good hygiene tools or the ability. You go into this doctor's office, and in order for you to examine me, you're going to tell me to disrobe. So I'm thinking, man, my underwear are just so bad. I do not want to let somebody else see me in those dirty underwear. Or I don't have underwear. So no, I'm not going in there. Nope, I'm good. And at first, when I was thinking this, I'm like, that can't be right. But then when I started doing the research and asking when people can answer anonymously, that's what I began to discover. That a lot of the homeless population, chronic and persistently mentally ill, substance abusers, it's the dignity factor. So I was knocking on doors from charities and commercial insurances saying, listen, if you really want to do preventative medicine, you got to fund underwear. They're like, what do you mean? I'm like, you got to buy underwear. So imagine this. You go into the doctor's office, and when they put you in the room waiting for the prescriber to come in, when the nurse has or the MA has escorted you in, they're going to see on the shelf underwear. And it says, free, help yourself. So before the prescriber comes in, feel free to help yourself to anything on this shelf. You got time to change into it. You got clean underwear on, and you don't put the whole inventory out there, just enough for this person when you know you're prepping the room. So they're at liberty to take it all, and you don't lose the whole inventory. Right, you don't care.
Yeah.
You kind of want them to.
You kind of want them to.
Take it. It's okay.
Correct. And then they're going to come back. Even if they only come back to their next appointment because I knew I'm going to get new clean underwear.
They came back.
And you get to do the treatment.
Yeah, it's better than nothing.
Correct.
And at least it's a level of encouragement, or
Correct.
they're aware that you're aware of their concerns.
Correct.
So there's a level of comfort now. You're building clinical rapport, and you hope that you can help that person a little bit more, rather than them no-showing chronically, not being able to make it, or having zero interest.
So do you guys
Correct.
institute this now?
No, there's a long story about why it's not
Yeah.
implemented, but basically I need the funders or the support to get it done. That's all.
Yeah, I mean, everything comes to finances, of course.
Yeah.
Even if it's a $2 underwear, it's still 2 times
Yep.
a ton of people.
Correct.
20,000 patients, a lot of people. So a lot of
Right.
underwear is buy,
Now,
but doable.
Yes.
But the health plan should get on board with it because it makes more sense for them because they come to their care. We were on a call yesterday, for instance. Look, now I'm talking. We were on a health call yesterday, and it was about kind of about comorbidity, but it was about weight gain. It was about like dietary issues we have with our underserved population. This was MAHP yesterday, and it was really just kind of saying, well, how come that we say we want to improve their mental health for sure? We get that, like that's what we're here for sure. We tell you to take a medication with a caloric requirement sometimes, which is common, or just, hey, in general, eat healthier.
Right.
How do you tell someone like that, even someone who makes decent money, right, to eat healthier because it's more expensive?
Correct.
So I always give the example of the tailor. I grew up vegetarian, and I used to always say it's a funny joke is like a veggie sub at Subway is the same price as a meat sub.
Right.
There's just less food in it,
Yeah.
right? Like you just took out the meat. And the same
Correct.
price.
it's a great example, though.
Like I'm like, this doesn't make any sense to me here, right?
Right.
But you still do it. But if you tell someone to eat healthy, it's not really affordable. So we're trying to come up with the mindset of like, do we give healthy meals out to people that would make sense for them? But this should come down to the plans. The same way some of the commercial plans pay for your gym membership now, like through your
Yep.
HSA and stuff, they pay for it, right? Because they want you to go to the gym. Like, of course, that makes a big impact for sure. But that's like a membership. Like, you don't even know if you actually go.
Right.
This is saying, what if they actually said, like, hey, for the underserved population, their meals were subsidized, so they got healthier meals, so hopefully diabetes, less stuff, less issues, all this kind of stuff gets better.
Yeah, I think we should be able to prescribe food as medicine because
Yeah.
it is medicine,
Yeah.
right?
yeah.
And it's the same thing. And I will say this too. In my piloting of the Project Dignity Meridian Healthcare, they stepped up and helped me with the pilot for a little while. It didn't continue, but I gotta give kudos to them because they really care over there.
Nice.
And it's nice to see somebody come to the table
Yes.
to address some of these very real needs. And it's interesting because our conversation here is such a small microcosm. Now think that is 1/20th of that patient's concerns.
Right.
And maybe we addressed
Exactly.
one thing, but then you start to see the larger picture of what else is going on. So that's just a level of the person feeling ashamed, feeling
Yep.
discouraged. But then what are the other needs? That may be a mental health appointment.
Correct.
So now you're trying to address the underlying need. You're trying to help them with self-image so they feel comfortable enough to receive the care they need. Then they need a high level of care. And then we as prescribers and providers have to focus on mitigating risk. So it all plays a role. It all informs that patient's appointment and all the factors that I feel we have to consider when we're treating these individuals. It is not straightforward. It is not cut and dry. And as Sarang always likes to say, we do not take a cookie cutter approach. You
Right.
have to customize care to the individual, even more so when you're speaking about the community centers and community health centers.
Yeah, absolutely. I mean, individualized services is not a cliche. You have to tailor it to that individual if you really want them to get better and you want them to take advantage of every opportunity that is there for them.
Yeah. And you need to find a way to, I mean, it's finances, right? At the end of the day, we're all talking about how do you fund a lot of these aspects of it. You can't decrease the financial burden of the system unless you fix the underlying root cause. Right now, we just throw a bunch of Band-Aids on.
Yeah.
You have this issue, here's a medication. You have diabetes, here's medication. You're gaining weight, here's this GLP. You have this thing, here's this medication, right?
Right.
But like some of these things are so easily or could be more easily preventable if you just treated it earlier, gave them healthier foods. I'm not saying buy them like crazy meals.
Right.
Just cheap, affordable, healthy meals. Like partner with somebody locally, whatever it may be. Do that to kind of do it. You know, I'm biased there, but try to do that if you can do that for sure. Or give them like a care package. When they come into the clinic, give them underwear, toothbrush, and some socks.
Right.
Maybe the socks help. They're wet, especially in the winter months here. You get less of that skin issues like ulcers and sores and all that kind of stuff, right? So maybe these are things that are like, and they're not that expensive.
That's the biggest thing. They're not that expensive. And when you look at the grander scheme of care and you're looking at a comorbid population, you want to look at every social determining factor that is influencing whether or not they're going to continue with their treatment. So why not do it? Why not factor it in?
Right.
Dentists are the only ones, right? When you leave, they give you toothpaste, floss, and
That's
toothbrush.
right.
They're the only industry that does that.
Right. Self-sustaining.
Do podiatrists give socks? I wonder if they do.
Maybe so.
Not the ones that work with us.
Right.
See, they should get free socks.
Yeah.
They don't get
Hospital socks at the very
Yeah,
least.
grippy socks.
Two things I think we'd be remiss to not mention here is one, some of the medications that we utilize within psychiatry are absolutely necessary. So I just want to talk for a brief second about necessary, meaning this may satisfy this client's need to have stability, whether it's for a bipolar disorder, a psychotic disorder, et cetera. We know the potential long-term ramifications, but we also have to treat what's right in front of us. So we have to make the educated decision and use evidence-based practice to say, this medication is going to be the best option for you, but here are the potential side effects. Here are the potential long-term ramifications for your metabolic profile and your physiologic profile. Let's talk about it. So I do think as a provider, it's important of us to set that expectation and that timeline to note that, hey, I do think this is best for you, but this does come with a risk. Would you guys agree?
Yeah.
Oh yeah, I think the one thing that pops in my mind, and I'll tell you when it pops in, every time I see a commercial about medication, and they list that really fast list of side effects at the end, and I'm like, well, when does that kick in? When am I really at risk for that side effect, and how long am I going to do this before then? And if I have to stop this, do you have something ready for me to transition to?
Wonderful questions. Exactly. And I think every client, every patient, every consumer has to think like that.
Yeah.
And ask those questions because there are answers.
And if not, then I'm like, then I got to decide if these side effects are worse than whatever I'm treating with this medication.
Right. Are the voices loud enough? Are they command hallucinations? Is it as much of a deterrent to my day-to-day life as it's going to be if I all of a sudden am diabetic and I'm experiencing DKA or having these hyperglycemic spells and hypoglycemic spells where I'm passing out or requiring hospitalization? So it's a very fair point to make.
Yeah.
The second thing I want to bring up is to your point about food and coordinating healthy food. Is there data out there? Is there enough information that speaks to decreasing the risk of hypertension, hypercholesterolemia, diabetes type 2, and other common comorbidities associated with weight gain or unhealthy eating habits versus, in terms of hospitalizations, negative outcomes, versus if they were eating well and if you could put together some sort of a meal plan of sorts? Could you pull enough data? Could you make enough of a case that A, you're going to save X amount of money on hospitalizations by just feeding this individual, this family, this group of people the right way? How do you do that, right? It's a huge picture to paint.
I don't know if you have enough. I don't know if you really can do that because you'd have to do two different ways. You'd have to say how this particular individual,
Right.
I mean, you could do two different groups, but this particular individual, how their health deterred by not giving them healthy food, and then also then saying give them healthy food, how it would do too, but you're at a later part in their life. So you have to do two
Cohorts.
cohorts. They're almost like identical twins almost, if you really want to get to it, right? And one runs the parallel of what we do right now with the food that we do right now. One does, and both the same healthcare aspects you get, and one does healthy food only that the insurances or whatever are subsidizing, whatever it is, and you can kind of track them and see how they would go throughout time
To establish equivalency and then to paint the contrast picture. Yeah. But it's hard to do.
It's very hard to do because there is evidence and information rather out there if you look up food as medicine, and you'll see it. But going back to your earlier point, how do you afford it? Mm-hmm. How do you get to the point where I can afford it? So when you tell me I'm going to basically go to this vegetarian diet and I'm like, okay, where am I going to get this money to do this? The companies that sell organic, the company that sells whole foods is very, very expensive, and I'm not going to do it. And then how sustainable is it? Because some of the health plans are now advertising, we give you money for food, for this, right? Help you with your housing. But when you have this person in front of you as a case manager in community health, we say, hey, they're giving you money for this. Yeah, well, the money is like $15 for the month.
Right.
$10. And you're like, what is that?
Where does it get you? A loaf of bread?
Yeah. So for the health plan, going back to like the underwear, on a larger scale, I got to do this for 10,000 people. So yeah, I'm giving you $10, but I really just gave up $100,000. And but
one person getting sick,
one person
in the hospitalization is $100,000.
Yeah,
$2,500 a night for a bed.
Yeah, so you know what I mean. So it's like
you'd need a pilot case.
I mean,
you would need
the thing though. If
an example,
if it's all preventative medicine, right? If it didn't matter, then the insurance companies would not pay for your gym membership.
Right.
You know what I'm saying? Like even if it's $30.
A lot of the Medicares do, right? A lot of the Medicare Advantage plans will pay for.
A lot of the commercials, like Blue Cross,
They're paying
too.
for it now.
They pay for it. They're part of your plan, so they'll say, "Yeah, we'll cover your gym membership, whatever it is per month." So think about how hard it is to track that. Like, you know that might help your physical health, diabetes, weight, all that kind of stuff. But we're talking about even before that, just even as kids.
Yeah.
I think it's because that's set cost versus variable cost. A gym membership is a range. It's a generic range for Crunch, for Lifetime, for you name it. It's a set cost that they can equivocate or calculate versus feeding one individual versus feeding two versus feeding seven is difficult for someone to.
But even if you something that's
evaluate.
like, I'm not saying give them free food, you know, it's not practical. But even if you give like one healthy meal,
it's better than none.
Better than nothing.
They need to partner with a grocery store chain. They need to partner with a Kroger, with an Aldi, with Meijer, with something where they'd be able to access
we
it.
know that our federal government knows how to do that because of the EBT program.
And WIC, right?
Yeah, correct.
Both of those
they know
programs.
how to do it. So now the question is, you know, how do we broaden it? How do we make sure that it's going down the right path? Because years ago with WIC, I remember if you were on WIC, could not buy cereal, for example, that had sugar. It had to be the plain, I'll call it, what was it called? Quicks.
Shredded wheats?
Yeah, like that kind of
That
cereal.
kind of,
you could do.
No sugar added.
Wheaties, cornflakes, you could do that. But if it was something,
Have you heard of Weetabix?
No.
if it was something with a bunch of colors and sugar, it wasn't on the list.
No Fruity Pebbles.
Yeah, correct. But now I think that's changed because they're just like, hey, at least you're eating.
At least you're eating.
Yeah. But I think we need to go back to medicine.
It should be the no sugar.
It should
be the no sugar.
It should be the healthier choice.
You can't use this and then go buy Coke.
Right.
Like, what are we doing here?
Right. And now, let me tell you how bad it's gotten.
Soda pop.
Let me tell you how, more than just a Coke, right? Because now you can go to any restaurant, or any gas station, 7-Eleven that has prepared foods, and you can use your EBT card there.
Oh, get a little taquitos.
Right.
Yeah.
Right.
I like me some taquitos.
Yeah, but if you think about a healthy diet, am I going to eat that every day because I can?
No, but if it's affordable, shoot.
But if it's affordable, so that's what they're able to do.
I have a quick question about that.
Yeah.
For places that advertise that they take EBT and WIC, those types of programs.
Yeah.
They enroll in those types of programs.
Monies.
Often they have signs on the store that'll be like Liquor Lotto Pizza, right?
Mm-hmm.
Those types of things. Are those exclusive to food products? The benefits that they have, because those places will
you can't use EBT for like
you
liquor
can't use it for something
Yeah,
else.
you can't use it for liquor.
Not that stores don't take it, but you're not supposed to.
My side question was going to be like Kratom. I mean, there's like a huge endemic right now with Kratom and other types of over-the-counter pills. I was just reading about this the other day. So I was curious if any of these programs cover those types of things because it could feed a bad habit as well.
Yeah, it doesn't. So they have those rules in place. And then one of the things they do with EBT is they'll send fake people in, like from the government, to go and see if you're going to let them buy outside of it. And they're pretty strict on it.
Good.
If
you can't buy like cigs with it, tobacco.
Yeah, I would imagine that there would be no vices, but you
No
always want to be sure.
Zins.
Yep.
Yeah. I think this was a nice topic.
Yeah.
I really appreciate where this went. I appreciate the perspective. And I like to be able to think outside of my own scope. It's a bad habit of mine to think about the private practice setting because it's what I'm able to speak on the most. But I appreciate both your perspective and your perspective. Being able to look at this conversation through a different lens is really illuminating.
Yeah.